Good evening, everybody, and welcome to a live event from the COPD Foundation and the new COPD Foundation Nebulizer Consortium. My name is Mike Hess. I am the Senior Director of Patient Outreach and Education at the COPD Foundation. I'm joined tonight by Dr. David Menino, co-founder of the COPD Foundation, as well as co-chair of the new Nebulizer Consortium initiative. Unfortunately, due to an unforeseen circumstance, our third presenter, Jan Cotton, COPD advocate extraordinaire, was not able to join us in person tonight, but she has graciously provided us with a lot of her written commentary that will hopefully fill in some context from the patient perspective as we go through some of the questions tonight. As you can see, we're going to be talking about the brave new world of nebulizers, COVID-19 and you, and we're also going to be discussing the new, as I mentioned, the new initiative from the COPD Foundation. So, without further ado, let's go ahead and get started here. Here we are with our three planned presenters, and this is, again, an initiative of the COPD Foundation as part of our ongoing commitment for education for the patient, caregiver, and clinician communities, our entire community altogether, and to improve our research efforts. Like anything at the COPD Foundation, this is a 360-degree approach, and we're very excited to be moving forward with it. So, by means of introduction, what we're going to do tonight is, even though 2020 maybe wasn't the greatest year to have a review, but we are going to think back a little bit to where we were in spring, not quite a year ago, at the dawn of the COVID-19 era. We saw a lot of questions about how we're going to treat this new novel coronavirus. We saw a lot of people going into the hospital and getting a lot of different treatments. We knew that part of the way this thing was spread was through aerosol droplets in the air. And so there was a lot of thought about we need to reduce the risk, particularly for our clinicians, by maybe reducing some of these aerosols that are coming out in the air. And of course, one of the things you see most often with aerosols is the aerosol droplets floating outside of a nebulizer, whether it's a mouthpiece or a mask, or depending on what type it is. So the thought was we needed to cut way back on some of the nebulizer usage and switch to metered dose inhalers, your traditional puffer. And that had kind of the unforeseen effect of creating a great deal of inhaler shortages. We can see the picture on the screen here. The FDA had some current drug shortages back in the spring of albuterol inhalers, where people outside of the hospital couldn't actually get the medications they used to get through their daily routine. So there was a lot of question about what we should be doing about this. And Jan had some great insight about this because she actually saw this process from both sides. She did have an admission into the hospital for a little while, and then also was nebulizing at home outside of her acute phase. So she mentions that at home, her nebulizer treatments really remained the same. Her equipment remained in one area and was used at the same times daily. In the hospital, treatments were scheduled that way, but because of workload issues and everything else, that wasn't always the case. So sometimes the nurses would have to go call the respiratory therapist several times before she could get a nebulizer treatment, which was very frustrating, as she says. There was a great deal of confusion as to what meds were to be used. It gave her a lot of comfort to know exactly what she needed, and she could convey that to the respiratory therapist when they came on scene. Of course, all that information had to be approved and put into the computer, which only prolonged nebulizer treatments that she had originally needed an hour earlier, but then all the workflow issues and everything else. In addition, COVID had everyone doubting every move they made, and many mistakes were made. If respiratory was too busy, the nurses would try to give treatments, which she describes in her words as a nightmare. She knew what she needed and how it was done. There were patients that suffered tremendously because they could only depend on the hospital staff who maybe weren't as familiar with care. It was understandable that something very serious had invaded the healthcare system and everyone was trying to adjust. And really, that's kind of the crux of it here, is how do we adjust to this issue? The COPD Foundation's response was to create a new collaboration. And so in partnership with Theravance Biopharma, the COPD Nebulizer Coalition was formed, which was intended to be an interprofessional multi-group effort between industry, several nebulizer pharmaceutical manufacturers, equipment manufacturers, some clinical and scientific experts, a community liaison, and a government liaison as well. Dr. Menino, could you explain to us a little bit more about the strategy efforts for the consortium?
Yes, thank you, Mike, for that nice overview to start, and I'd be happy to. And there are three basic pillars that this consortium will have moving forward that are depicted on this slide. And the first is research. As you'll see as we go through our the next 20 or so minutes of this presentation, and you'll see that there are a lot of questions that remain. There are questions, for example, related to the amount of virus that may travel, when nebulizers are being used, and importantly, how that may differ from when nebulizers aren't being used. One of the critical questions to me, for example, is yes, and we know that a patient in a room who is infected is shedding virus. Does that shedding occur differently whether or not they are using a nebulizer? And I think, as Mike alluded to earlier, and the visual effect when you see a nebulizer being used, you see this mist coming off the back. And I think that is a visual that when we talk about droplet or aerosol spread is an important visual, but it may be unrelated to the reality of whether that creates a situation that is more infectious than that person just sitting in the room, breathing and coughing. In addition, and we need to have research that better understands what is happening clinically, both at in-home and outpatient, inpatient situations. Projects that really focus on the patients. We heard a little bit of Jan's story and how this affected her and was frustrating. And of course, the ultimate goal of our of any research that we do is to disperse what we do out to the broader scientific community. So, publication remains important in that research pillar. And the second pillar relates to education, and this is education of healthcare providers, caretakers, and patients. And this is actually what we are doing tonight is part of that effort of increasing the knowledge level of our COPD community. And as part of that education is also educating decision makers. We call that advocacy. And that relates to decision makers, both in hospitals and legislatures and other places, where people are in a position to make decisions that affect our COPD population. And then in addition, this and other programs that will target healthcare providers, patients, and caretakers. And then the third pillar relates to guidance. And again, and this is somewhat related to this advocacy effort, but certainly we want to be sure that there are guidelines that are developed and implemented that protect the COPD patient who needs these therapies, and also, of course, protect the healthcare providers that are caring for these patients. But these have to be done, based on science and not just what some people think may be correct.
Those are very important points. And on that note, we do know a little bit about how viral transmission works. We've had some previous studies and some previous science behind a lot of this stuff. So, Dr. Menino, I'm wondering if you can continue on and give us some idea about what do we know about viral transmission?
Absolutely. We'll go on this slide, and this is a very nice pictorial in that on the left-hand side, we have a person who is infected and is shedding virus via coughing and other mechanisms. And we have a couple of slides up that will show you, when a person sneezes or coughs, for example, they can produce both droplets and aerosols. And with the difference being, that droplets tend to settle faster onto surfaces, whereas aerosols tend to stay in the air. They're dispersed for a longer period of time and tend not to settle. And they can also spread a further distance. So this says more than a meter, so more than 3 feet. And people So the blue person on the right end of the slide can be infected via both aerosols and droplets. With aerosols being what they breathe in, and droplets can also infect. But this is based on since droplets settle on surfaces. This is that sort of hand to mouth action. So this is why it's critical. Not only to wash your hands and take care of hand hygiene, but also to wear masks. And we'll show you on a visual in a couple of slides how this may work. Go on to the next slide, please.
Yeah, because if that wasn't complicated enough, we also have to deal with different types of aerosols, don't we?
Yeah. Yes. And this complicates. When we talk about aerosols, we're not just talking about one type of aerosol. And I tend to think of aerosols as being, on the far left, that bioaerosol, that is a person coughing. And we have a nice visual on the next slide that will show that in more detail. But they're also, these in the middle section, and you see an aerosol that comes out of an MDI, or even a nebulized device that may not have a person attached to it, and this is of course not infectious, and there are no viral particles in here. Now there are other aerosol generating procedures, such as if a person is getting a tube put down their nose or throat, that may generate an aerosol, but that would be probably more lines of a bioaerosol than this type of medical aerosol. And then, what we have on the far right is this fugitive aerosol, and this can be viewed as a combination. This is not only what's, for example, coming off of a nebulizer that's being used, but is also combined with what a person is exhaling. And this is where there are a lot of unknowns that we don't know whether, for example, and this generates more viral shedding than a person that is, say, just breathing. So this is an area of research. When we talk about research that needs to be done, an area that's right for this type of research.
Definitely a lot of factors that go involved in transmitting these aerosol particles and potentially virus-laden aerosols. So here's that graphic that you brought up a minute ago, talking about the force of how much somebody's breathing or sneezing and coughing. What would you say the takeaway message of this particular slide would be?
Well, and you can't see the scale very well on this, but and you can just imagine that and this is why the recommendation is to maintain 6 feet of social distancing, because that is how far an unmasked person can potentially spread. Although and you can see, and the other sort of visual here is that you see some of these larger drops that are probably droplets seem to settle relatively quickly, whereas the finer fraction is more likely to stay suspended and spread more horizontally. And the other thing that is not sort of seen here, but you can imagine, is the importance of wearing a mask. If this person is masked, a lot of these larger droplets are going to be captured in the mask. So. And I can say, occasionally I've been walking through a grocery store and a person is wearing a mask and they decide to take it off when they need to sneeze. I think perhaps we've all seen that. And it's like, well, that's not the way it works. It's you're supposed to sneeze or cough into your mask. But certainly, and these are some of the factors that, in fact, affect viral transmission in a nice, visual that also then shows, the importance of how masks should work.
And so then we can also look at the internal environment of a particular room, and we may get into this a little bit more when we're talking about nebulizing at home. But this can have a pretty significant impact on viral transmission as well, can it? Particularly maybe with some of those finer particles that tend to stay in the air a little bit longer.
Yes, and which side of the room would you want to be in? The smoking section up top or the non-smoking section down the bottom? Uh, and you could tell that this is a bit of a dated slide because you see down the bottom there are 10 people around an 8-foot table, which in the in the COVID era, this should not happen unless everybody was wearing a mask, and even then, I would not recommend it. So, but certainly, the idea of in that area up top, and there's no amount of improved air circulation. You need to have like a jet engine, moving air through to make that a safe environment. So, so there are multiple factors that one needs to consider, but the most important one is how many people are in a confined space.
So now that we've looked at some of the basics of viral transmission, let's take a look specifically at what we know about some COVID-19 aerosols.
This looks at, although SARS-CoV-2 on the far right emerged in 2019, coronaviruses have been around for many, many years, and the novel coronaviruses, which would be SARS-CoV-1, and then MERS-CoV, which appeared in 2002 and 2012, respectively, added to our knowledge base, so that we at least knew a little bit of what to prepare for, and we'll be talking about that in subsequent slides. Although, and you'll see the work on SARS-CoV-2 or COVID-19 at the far right, we're still building a knowledge base, because if you look down the bottom, for example, it's this case fatality rate, and which has a very wide range, and this is the percentage of people who are infected who die. And it goes from 1 to 25%. And this was an early estimate, and probably the estimate now is probably more in the range of 0.5% to 1%, which is far less, than what we saw with MERS, which was around 35%, and even less than what we saw, and less than also what we saw in the first SARS, which is around 10%. But the flip side, in SARS-CoV-2, seemed to be much more easily spread. If you look at some of these other estimates of how quickly it spread around the world, it's affected a much larger proportion of the world's population than either of the other two.
And so it's safe to say that even though these viruses do tend to have some significant differences, we can extrapolate a little bit of information. We can draw some conclusions based on our experience with these previous viruses. So taking that into account and looking at some of the early information that we had from the pandemic, the Department of Veterans Affairs, in conjunction with a couple of other groups, decided to do this or undertook this ultra rapid review of some of the information that was out there from previous pandemics, as well as what we knew from the get-go. And so this pull quote at the top here, in the current COVID-19 pandemic, it is common practice to avoid the administration of bronchodilators via nebulizers because there was this concern of transmission. And so this was a big reason that they wanted to undertake this, and again, trying to get some more of the information about exactly how contagious this thing is. And so looking at this review, they concluded that evidence that exposure to nebulizer treatment increases in transmission of coronaviruses similar to COVID-19 is inconclusive. But there was minimal evidence about SARS-CoV-2 specifically, because again, this was very early on. You can see the date here, April, May, a couple of months into the pandemic. However, they didn't want to rule out the possibility that nebulizers could increase viral transmission. They couldn't rule it out. And so we can also take a look at some of these other previous studies and see exactly what those folks were looking at and what kind of information we can get out of it as well. So Dr. Menino, can you give us a quick rundown of these three studies?
Yes, and you can see from the dates on these that these were related to earlier infections. And these were related to the MERS outbreak that occurred around 10 years back. And the paper from Tran on the far left suggested that things such as nebulizer treatment or high flow oxygen or even BiPAP were not significant risk. In other words, that this did not increase the risk of transmission to other people or healthcare workers, in addition to just being in the room with a person who was infected. Although the sort of a cautionary note in the next tale is that nebulizers do disperse exhaled air through that generation of aerosols more than a meter from the person. Although we also know that the further away you are from that nebulizer generation, the less likely you are to have exposure. But of course, the question is, well, is there significant virus in that exhaled air? And then, and the third point on the far right points to ventilation or air exchange being the best way of reducing aerosol exposures. And this is why you have in hospital settings, for example, isolation rooms, that have that are pressurized in a way that air does not sort of flow out of that room.
So based on these studies, what we kind of knew is that the risk was relatively low. We knew that if you were standing maybe more than a meter, which is where they come to that 6 to 8 feet of social distancing idea, and if you had decent ventilation, you could essentially minimize your risk. Is that fair to say?
Or decrease. Again, because to me that the question is, are any of these things any more risky than just being in a room with a person who is infected and coughing? And that I think is the critical question that I had not really seen answers to.
And speaking of not having answers, we do know that there are some other significant knowledge gaps out there. So we've got another quick rundown of some of these papers that are out there. These are a little bit more recent vintage, I guess I would say. So can you go over these real quick for us?
Yes, and this sort of highlights that, for example, in the Woods paper, that there is no clear evidence that nebulization is able to transmit viral particles. The middle article from Dr. Sanjay Sethi, who happens to be one of the experts that's part of our consortium, notes that, and this is important to when we talk about individualized therapy, that in the absence of this sort of clear data, that we really need to be sure that we're using the right therapies and the right tools for the right patients. That a one-size-fits-all approach does not make any sense. And then in the final article on the far right by Fink suggests that. And that this sort of points back to Dr. Sethi's paper that the idea of wholesale changing a person, say, from nebulized therapy to MDIs when MDIs may not be appropriate for them, it does not make a great deal of sense, in that there is no evidence that one form or another either increases or decreases the risk of viral transmission. So, what seems to make the most sense is to continue to treat the patient appropriate for their condition.
And indeed, we even have some nebulized medications that are coming out to help treat COVID-19, don't we?
Yes, and that is certainly in the development stage, but that is certainly something that we'll continue to keep an eye on.
All right, so this was one of the biggest earlier studies that again came out of Wuhan, right at the source of where SARS-CoV-2, the virus that causes COVID-19, kind of really where this came out. So Can you highlight this a little bit? Does this answer any of those questions, or at least take us closer along the path to trying to get some of those questions answered, even though this was early
Well,
on?
yeah, well, there are a couple of interesting components of this paper. The one that's when you look at aerosol inhalation, you'll see on the left hand side that doctors basically did none of this. It's like zero, 100% had zero exposure. So this is all being done, I guess, in China by nurses and other healthcare providers. The key point down here is that no participants converted based on their exposure or lack of, even though people were being exposed. But of course, and they were all wearing full personal protective equipment, including N95s, during all procedures. And this may be the critical. And I think one of the things that we may take home, from what we've gone through over the past year, is to take the respiratory spread of viruses more seriously. And I think, we have, I've often said that, this reminds me, I'm old enough that I remember the early days of HIV, where bloodborne infections prior to HIV were treated somewhat cavalierly. And then it wasn't until after HIV that all of a sudden you saw universal precautions that you assumed all blood was infected. And I envision a time in the future where, and it may not be to the same extent that we're seeing now, but if somebody comes into the ER coughing, they're going to get a mask put on them, before they step foot in there, as that should be, and should have been the case for years, and no longer considering it acceptable to have people sneezing uncovered. Just get a mask put on. I think that's going to be the new norm going forward, even after we get through this COVID nightmare.
And so, as one of those respiratory therapists that tends to be the ones that are doing the treatments and everything else, I like this idea of what they call the Swiss cheese approach, where no single intervention is necessarily going to be the answer. We've talked about social distancing. We've talked about wearing masks and other PPE. We've talked about putting masks on other people or not going places if you're sick. We've got vaccines coming down the pipeline now. So we have this idea where if you have a breakdown in one layer of your defense, it might get through a couple of other layers as well. But the more layers you have, the more different factors that you put into play, whether it's ventilation, whether it's masks, whether it's hand washing, you have a better chance of, as you said, minimizing your risk. And so that's why we at the foundation and in the consortium have really been looking at not only always following up-to-date guidance from CDC and all the other organizations and best practice guidelines and everything else that comes along, but try to use as many of these interventions as possible. Looking at...
and this might be...
Oh, go ahead.
Yeah, this may be my favorite slide in the deck. I particularly like the mouse that's climbing up that one piece of cheese there. That's actually sort of nibbling a hole. But this has sort of been a standard in the world of occupational health and prevention. When I worked at CDC, we always talked about these sort of multiple layers of prevention that. Because people that think that a vaccine is going to sort of fix us all, well, that's one piece of cheese. You need and you need multiple things, and you need to sort of put out the mouse traps to keep things from eroding, because it truly does take multiple interventions to get this to work. So. Even though I've had my first vaccine shot, and I'm planning to get my second one this coming week, but I'll be wearing a mask for the foreseeable future, and that's just to be safe. I think you can't be cavalier about this.
And to that end, Jan had she wanted to focus on one of those things that often gets overlooked, particularly with nebulizers, is making sure you're keeping things clean. making sure you're wiping everything down. As she said, her routine for nebulization was essentially the same it was before the pandemic, but she was very diligent about a lot of this stuff. I wash my hands. She washes her hands before use. She makes sure her machine is clean at all times. Her filters are changed. Her medicine cups are changed every couple of days. Since this was already her routine, she says, she didn't have to change anything because of the pandemic. She's always been careful, but she really wanted to highlight that it's, especially now, it's absolutely critical to, again, follow all of these steps, make sure you're using every possible tool you have in order to keep yourself safe. And that's because as clinicians, we really need to consider nebulization for essentially every patient. We actually have some evidence-based guidelines that came out 15 years ago now. Unfortunately, a lot of people aren't necessarily familiar with them. And so we look at things like availability and cost and how long does it take to do the treatment, and is the person able to use their device well? Are they able to keep up with cleaning of a nebulizer? Are they able to squeeze the metered dose inhaler? Are they able to generate that inspiratory flow for a powder inhaler? Is it something that they're able and willing to use as we get into convenience factors and things like that? All of these things really need to be taken into account, and they're often not. This is another place where Jan was mentioning that despite being a patient and a user of inhaled medications for better than 20 years, she has to say that she has never had, at the beginning of her diagnosis, she did not have any input on her medication. Over the years, she came to learn what worked best for her and can now let her doctors know what she wants. But she says all the testing about inhaler technique and training on usage came from respiratory therapists and the COPD Foundation. And I think that's where we are. Maybe Dr. Menino, you can speak to this from your pulmonology perspective. But I think that's really where we are in a lot of cases, where we see we've made a decision for some reason, for example, here in the pandemic, that this is the med and device you're going to get. And maybe we should be looking at a little bit more of a collaborative approach.
Absolutely. And this goes back to the right therapy for the right patient, that there are, and I think we have, certainly, one of the challenges that I know occurs in my patient population is sometimes it's outside forces that dictate what the patient gets. It might be what their insurance will cover, or that might dictate things. And although nebulizers are great options, that there is challenge related, for some people, related to keeping them clean and up to date, or even putting them together. So I think these are all things that need to come into that we need to consider, and we need to continue to develop. Part of what I think the Nebulizer Consortium is working on, as well as the COPD Foundation, is to look at innovative ways that we can improve delivery of therapy to patients. And I know that some of our industry partners are certainly interested in doing this too, because if you could have the best therapy in the world, but if it doesn't get into the patient appropriately, it's not going to do any good. And there are multiple ways along the way where things can go wrong. So we need to be sure that the patient is able to use the therapy, that they're getting it, and that it's delivered safely to them, and also in the context of this COVID pandemic, that we're also protecting the people that are around them.
Those are all fantastic points about looking, and that lead us well into looking ahead, particularly now that we do have a couple of vaccines out, a couple of more vaccines on the horizon. There does seem to be a bit of a light at the end of the tunnel these days. However, we still have some pretty significant gaps in our knowledge, wouldn't you say?
Yes, and we've already mentioned some of these. Certainly, and the future may look at some nebulized therapies that are actually used to treat COVID, in addition to looking at various nebulized therapies in patients that may have COVID, who also have some underlying respiratory disease. And we've spent a lot of time talking about transmission risk with various types of devices, and these are knowledge gaps that really need to be addressed. So further recommendation and guidance can be science-based rather than opinion-based. And as we look at these other risk factors, something I've mentioned several times is is the risk any different in a person? So if you walk into a patient room and they're using a nebulizer as opposed to walking into that same room and they're not using a nebulizer, I don't think, I'm not aware of data that's actually looked at that type of question specifically. And if the answer may be, well, and you just have to use the appropriate personal protection regardless, which I think is probably going to be the correct answer. But again, that's my opinion as opposed to something that's based on science. So we need to really do the work to better understand that.
All right. So as we get toward the end here, we've still got some time to get any questions that you might have submitted into the feed here. The big question of the night is nebulization safe? And our contention is, by and large, the answer is going to be yes. There are certainly some questions that need to be addressed, but we know that particularly for people who are using nebulizers in the home setting with appropriate ventilation, with appropriate distancing, for you clinicians out there who are using them with proper ventilation in your rooms, proper personal protective equipment, filters, all the environmental and engineering factors, all of these things working together can allow nebulization to be safe. There are going to be different requirements in different settings. Not everything is going to be a one-size-fits-all solution or look like other solutions or anything like that. But by and large, nebulization can be accomplished safely. We did see a recent letter to the editor in the Journal of the COPD Foundation that told us that data on COVID-19 transmission by nebulizers in a hospital or office setting is limited, but the article was also very clear that home use did not include any known risks to individuals, including those with COVID-19. So I know there are a lot of people out there who are worried about perhaps they don't know they're infected and they're concerned about infecting family members and things like that. And the answer is you should continue to do your medications as prescribed because the risk is relatively low. We do also look forward to being a trusted, credible source as we go forward, whether it's foundation materials. Hopefully we'll be seeing a lot more coming through from the consortium. As Dr. Menino mentioned, this is kind of our initial effort. We look for a lot more coming down the pipeline as we engage our research divisions and continue to improve our advocacy components. And this is where Jan had one more message, and so I want to kind of give her the last word before we get into questions. And she mentioned
patients should always have the last word.
She says the pandemic has brought awareness to hand sanitizing and sterilization in the hospital setting, which I'll tailgate on and say kind of worries me. We should have been doing that a lot before. However, in Jan's view, before the pandemic, not enough attention was given to those issues. It's also unfortunate that ERs don't want to nebulize when patients are gasping for air. The patient is in a room alone with no visitors. Only hospital personnel are allowed, and they're well protected. I think the jury is still out, in her opinion. The hospital staff now handles all nebulizer equipment with gloves. Should have been that way all the time. No argument there. Her personal preference on nebulizer equipment is to use the pipe or the mouthpiece. When inhaling, the medication gets deeper into the lungs. Of course, only when the patient can inhale deeply. The mask is useful for longer breathing treatments or for patients who cannot inhale deeply. The COPD community should be making sure their equipment is cleaned, their filters are changed, their medicine cups are emptied after every use, and only using a medication cup no more than 2 days and then changing it out. The hospitals are already stressed because of COVID-19, but there has to be some common ground on what's best for the patient. I am not sure if patients are in private rooms now. They were when she was hospitalized last year. So I think those are all fantastic words of wisdom from Jan. And I think that's a great place to end the lesson today. So we do want to, before we get into questions, I do want to take a moment to thank our sponsors and partners in the the COPD Foundation Nebulizer Consortium, the founding sponsor, Theravance Biopharma, but also Aerogen, Monahan Medical, Perry, our other partners who are coming on board as we speak, our subject matter experts, our academic liaisons, our government liaison. Also tonight, a quick shout out to Brett Denning, Stephanie Williams, and Susan Williams, who have been keeping an eye out for comments and questions for us, which we can get to without further ado. So let's take a look and see what has been coming through. I know we're not ever supposed to have dead air on live events. Trying to scroll back up a little bit here. I know we had a couple come in beforehand. Here we go. As copays increase for medications and MDIs, do you anticipate clinicians taking advantage of Medicare Part B or ordering these medications via nebulizer instead? Dr. Menino, you want to take that one first?
Well, yeah, and this has been going on for for many years, particularly in our Medicare population, where insurance coverage is different for nebulized therapies, relative to your meter dose inhalers or your other sort of inhaled medications. That may be, but again, and this gets back to the tailoring the right therapy to the right patient. While nebulizers are wonderful in some patients, and they are, challenging for other patients. For if I have a reasonably active, Medicare covered, person who can be managed well with a dry powder inhaler, it doesn't make sense to have them use a nebulizer because it's going to add to the complexity of their day, and you have cleaning issues and other things. The flip side of that is a person who is is hitting their meter dose inhaler multiple times a day, and need that just to get going in the morning. Probably makes sense for that and it was otherwise limited. That is a person where it makes sense to have them on some sort of nebulized therapy. But again, it's I think it varies by patient, and certainly going forward, when we talk about access to medication, the importance of co-pays and coverage continues to be an important issue that we need to better deal with.
So I have a great many thoughts, which is why I wanted to let you take that one first. In my previous role before joining the foundation, I was kind of knee deep in a lot of that stuff, working on prior authorizations and all those paperworks. And I really can't agree more that it has to be the right tool for the right person, whether it's medication, the actual molecules involved, whether it's the device. And that's where clinicians really need to be aware of all of their resources. I mean, we can break it down into kind of Part B versus Part D versus Medicare Advantage, but we have to understand how all these things work together and make sure that it's the best fit for our patients. Because you're absolutely right. If we're giving somebody a tool that they aren't able to use, aren't willing to use, frankly, then we're going to see worse outcomes down the road. And we also need to be very strong advocates for on behalf of our patients. Again, going back to that slide we saw where there were 8 different factors that we really ought to be taking into account when we're recommending or prescribing a medication. We should be looking at those, and we should be making sure that people who are making decisions As you said, some of those external forces are also aware of those guidelines, because I can tell you, in my clinical experience, I have dealt with many, many people who essentially thought they were interchangeable, because it kind of comes from that mindset of most medications aren't inhaled. So if you can swallow a pill, you can swallow a capsule, you
Right.
can swallow a tablet. But these are a lot more complex, obviously. So I'm hopeful we can do a more aggressive job of making sure that those decision makers are aware of those factors. So the next question we got is, can you touch real quick on using filters with nebulizer treatments?
Well, and this, we talk about research, and this is a hot new area where data is still being developed. I know, for example, and this isn't exactly on topic, but for example, in the world of spirometry, and we are starting to put viral filters on the back of spirometers, even peak flow meters, and they seem to have at least decrease the risk of viral transmission when a person is doing that forced exhalation. I have not seen data yet on filters on nebulizers. I don't know if you have, Mike, but and that's certainly, when we talk about levels of control, those slices of cheese, a level that is always one of the better ones is what we call an engineering fix. If you can engineer something to make it safer or less likely to transmit something, that is always a better option. So I don't know what you've read or experienced.
Basically the same. I haven't really seen a lot of data that has come out. I mean, intellectually, it seems like it would kind of make sense. But again, it seems like it could be a little bit of overkill. You talked earlier about the different types of aerosols with fugitive aerosols and everything else. Are those particles laden with virus? Are they transmitting? Are they a vector? We'll throw all the science words out there. We don't know. And
But
so,
and there may be smarter people out there than me. But for example, we know, like in the world of occupational health, that when you go from open systems to closed systems, and you decrease risk of exposure, and it may well be in the future that the nebulizer of the future might be a closed system rather than an open system. I'm not an engineer, so I have no idea how that might work or if it's even feasible. But I think it's certainly something to be considered.
so kind of along those lines, what are your thoughts about using a breath activated nebulizer? For those who may not be familiar, there are some nebulizers out there that are designed with valves or some other gadgets. I can't remember. I'm not an engineer. I'm a respiratory therapist, not an engineer. They only nebulize, they only create the mist when a person inhales. So it seems like, again, objectively, you're going to have fewer of some of those fugitive aerosols that may be increasing the risk. Would those be perhaps an interim solution before we get into one of these fully closed systems that you mentioned?
Well, I think that improves the visual, because I think what at least initially bothered people about nebulizers, you see this mist coming off the back. So with the breath actuated, and you're seeing less of that, because but if it does it actually make a difference? I don't know, but it could be that sort of technology takes us towards perhaps a more of a closed like system. And I'm sure, and I know there are a lot of smart people around the world that may well have worked on this as we speak, and may have some things in process. But yeah, I think one of the other things that we've seen with this pandemic is that it spurs innovation. And the idea that we could be doing remote clinical visits or having meetings and depositions and other things via Zoom was unthinkable a year ago, but now sort of like it's become the norm, and you sort of grow used to babies crying or dogs barking in the background as you're it just has become a part of life. And I think, and when I think over the next few months, we will return towards normal. But, I also think that part of these innovations will, also become acceptable. The idea of Zoom meetings rather than, flying halfway across the country for a 2-hour meeting, is we may sort of rethink how we do business.
So we did have a comment come in that mentioned Fink and Daly noted in their aerosol, in their paper, aerosol filters helped reduce fugitive particles, but not necessarily bioaerosols. So, again, is that reducing the risk? Since we don't necessarily know how much of those fugitive aerosols are laden with virus, we don't know if that's really a benefit or if you said it's kind of just for show.
Yeah, and that's where I think we need where more research is needed, so that ultimately we make decisions based on science rather than what we think is correct.
Did have another question before we get into that. As we're on the topic of questions, we have created a survey for folks to take who have been attending tonight. We're going to make sure it gets posted on the live feed itself. It's also in the event page that's associated with the COPD Foundation, so you're able to check that out. But we do want to gather some information about, kind of, again, what do you know, what do you don't know, where are knowledge gaps, what are the things that are important to you, so that we can continue to do some quality improvement, make sure our future efforts are hitting everybody's needs for education, and so that we can just continue moving forward as a community. So we do ask everybody, we'll follow that link. You can look for a link to surveymonkey.com. It is anonymous. It is not mandatory, but we really would appreciate your help so that we can plan better events and give better information going forward. So going back to the questions, we did have somebody ask if we could go into a little bit more detail about some of the medications that are in the pipeline coming out for COVID that might be nebulized.
Well, I'm not sure I can go into much detail other than, I've seen some reports. I haven't seen exact sort of clinical trials, or I could even tell you classes of medication. But I know in other when we look at other sort of viral diseases, that there are a number of different pathways that are being looked at that that may modify disease response, because the problem in the more severe response to COVID is almost an ARDS, an acute respiratory distress syndrome type of picture. And maybe one of the things that we can plan, this will probably be more for healthcare providers, rather than the patient community, although both be welcome, is maybe as we go forward into the future and look at other educational efforts, that might be one that we could get some of our academic partners who may be doing work in that area to give us some information on. So that's a great thought. But other than saying that work is being done in the area, I'm unable to give any more detail than that.
Fair enough. However, on the subject of healthcare providers and therapeutic options, we do have a question from a respiratory therapist. Do you feel there is an over-reliance on bronchodilator treatments for SARS-CoV-2 COVID-19 patients? This respiratory therapist has seen bronchodilators commonly ordered for respiratory distress from COVID without necessarily having evidence of bronchospasm. This increased use and change in delivery mode can lead to a decrease in medication availability for those who need it most for chronic conditions. So certainly agree with that last part. But in your practice, have you seen an over-reliance on bronchodilators?
I have not, but again, I think this is something that's going to vary from setting to setting. And I think early on in COVID, patients were being treated with everything from what I've had seen reported, and as and less of that may be occurring now, particularly as I think one has better treatment sort of pathways and treatment algorithms, but yeah, I think that's as we continue to see sort of data roll out from the clinical centers that can continue to treat a lot of patients, will get a better idea. But yeah, it seems like bronchodilators were being used and they're typically being used in people with respiratory distress, maybe not ARDS, but that has sort of traditionally been a mainstay of therapy. But I think as data emerges and as we see more data from the U.S., over the next several months, we'll get a better picture of this, and hopefully that will lead to a refinement on how to treat this going forward. Even though I think the hope is that with vaccine and as we move towards herd immunity, and we'll be seeing fewer people hospitalized with severe infection.
Great. So we're coming up on the top of the hour. We've got time for maybe one or two more questions here, particularly one that is really important, particularly for folks. We've talked a lot about therapeutics for the acute or active phase of COVID, but this question is about what about pulmonary rehab for post-COVID recovery? I know that's been a really interesting area of discussion and hopefully some potential research. I know it's been really difficult for a lot of pulmonary rehabs to be working up until the last probably couple of months, maybe depending on where you're at, couple of weeks. But are there going to be differences in how we design pulmonary rehabilitation programs in the future for folks who have gotten past that acute part, but are in the midst of what a lot of people are calling long COVID or COVID long haulers, where they're still just trying to build up weeks and months after their hospitalization or their acute illness?
Yeah, and I think there are and there's sort of two questions buried in there, and and one is sort of like the long hauler who was never really seriously ill. They didn't end up in the hospital. They just had a mild to moderate infection, but have continued to not feel well in the long term, including with some respiratory complaints. And then so that's sort of one sort of constellation or one set of patients. Another set of patients are those patients that had a more severe illness, ended up in the ICU, and have the usual post-ICU syndrome where they have the muscle issues and the weakness. If you take any even healthy person and immobilize them for a couple of weeks, they're going to have a need for some type of rehabilitation afterwards. So yeah, I think there's going to be a need and importance, and of course, for not only pulmonary rehab, but rehabilitation services in general, and whether these are provided in person or remotely is something that's going to need to grapple with. I know at our institution, and there is some grant funding that was recently awarded to look specifically at that within the context of our pulmonary rehab program. But yeah, I think this is going to be critically important going forward in those two separate populations, sort of like the long haulers who are never seriously ill, and then sort of the more critically ill patients who have all the usual ICU intensive care unit related problems.
All right. From Zoom meetings to Zoom exercises and Zoom pulmonary rehabilitation. Truly a brave new world. All right, well, that takes us up to 8 o'clock. I really appreciate everybody coming out and spending some of your Wednesday evening with us here with the COPD Foundation and the new Nebulizer Consortium. Again, thanks to Dr. David Menino for presenting a lot of great information tonight on what we know, what we don't know, and what we hope to know soon. We really look forward to a lot more of these kinds of events on getting a lot more information out there and helping the entire COPD community move forward together.
And thank you, Mike, for putting this all together. Mike was the ringleader who he had a lot more hair before this process started.
That's a scary thought, still rocking my COVID do. A lot more.
Yeah, that's a very and a lot of work went into this, including the other folks that you mentioned, and also a big thanks to Jan Cotton, who could not be with us in person, was certainly with us with her comments, and it was really sort of an inspiration behind why we really need to move forward with this.
Well said. So. Thank you again, everybody, for coming out tonight. We'll see you again soon. And thank you very much from everybody at the COPD Foundation. Have a great night. Stay safe, stay healthy, stay warm, and take care of yourselves.
Thank you all. Bye.